Now we're starting too late. Five, four, three, two, one.
Hello everyone, my name is Slavin Gojkovic, and I'm really delighted to greet this new hangout of students chapter of Neurosurgical TV. I'm broadcasting now from Zagreb, Croatia, which is dark here. It's 9 p.m. and I would like to start with the introduction of the panel. So, Rakesh, can you please say something about yourself?
Yeah, hello everyone. I'm Dr. Rakesh AV. I'm a neurosurgery resident from India, and I'm very glad to be a part of the student chapter of neurosurgical.tv. It was an initiative taken by Slavin, so it's already going on in flying colors. I hope this one will be a very successful one too. Thank you
Thank
for
you,
inviting.
Rakesh. It's wonderful to have you here. And Marco, can you please introduce yourself?
Good afternoon to everyone else. My name is Marco Antonio Calla. I'm from Cochabamba, Bolivia. I finished my studies the last year, and I'm a doctor right now. I'm really grateful to be here in this conference and also to learn neurosurgery. Very, thank you very much.
Thank you, Marco. It is great to have someone from from this part of the world here. And Armando, please tell us something about yourself.
Hello, my name is Armando. I'm from Cochabamba, Bolivia. I'm a student of medicine on the Universidad Mayor de San Simón of third year. It's a really honor to meet all of you and 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 share
Yes.
this experience with you.
Thank you, perfect. Okay, Abdallah, say something about yourself.
Hello everyone, I'm Abdallah Rada. I finished my third year of medical studies. I'm Egyptian, but I'm studying in the University of Carol Davila in Bucharest, Romania. So I'm going to the fourth year. I'm pretty interested in neurosurgery, and I'm looking forward to hearing that presentation.
Yes, another amazing presentation from our Bucharest colleagues in Romania, such as Abdallah did some few days ago. So, yeah, can you please, is your audio okay? Try to introduce yourself, or. Okay. Yes. It seems that your audio is not too well. Well, Leah is my colleague from Zagreb. She's a medical student and also my collaborator in many projects that we are working on there in the field of neurosurgery. So we're delighted to have you here. And Nicola, also my colleague from one team that is working on also on these projects. So Nicola, can you please introduce yourself?
Yes, of course. Hello everybody, my name is Nikola. I'm from Croatia and I'm really happy to see you all here, and I'm really happy to hear what Francesca will tell me.
Thank you, Nicola. So Francesca, sorry for the instructions, and it's all yours. Thank you so much for being with us tonight.
Thank you so much, Slavin. Hello, everyone. I am Francesca Ochea. I'm a fifth-year medical student from Bucharest, Romania. I study at Carol Davila University with Abdallah. And I am also the chair of our Walter Dandy Neurosurgical Club here. It's a club for medical students interested in neurosurgery. And I will talk today, I don't know, maybe tonight, because it's night here in Romania, about a subject that is dear to me, because when I first started going to the hospital in 2013, the first patient I met, it was a 51 years old woman with glioblastoma, and I know it's not maybe okay to do so, but we became really close. And she taught me how to fight, because she was I don't know, incredible. And she unfortunately died 17 months later, and it feels like she took a piece of my heart with her. And okay, I'm sorry. So I started studying, and I really want to tell you about this tumor. It is the deadliest tumor in the central nervous system, and we don't have so much. So many strategies to deal with it, because it's a really I don't know, good opponent. And I should start my presentation. Just let me see how. Okay. Is it okay? Can you see it?
Yes. Yes, we see the presentation.
Okay, thank you. I said the glioblastoma multiforme is the deadliest form of brain tumor with more than 90% 5-year mortality rate. And it has a median survival of 12.6 months. And this is because we have treatment limitations, such as the high average age of onset. You will see that most of the patients are elderly. I will show you later our experience in Baghdad Arseni Emergency Hospital. And the tumor location can also be difficult to approach. And we currently don't really understand the pathophysiology of this tumor extremely well, so we could target some specific features. And nowadays, the current techniques are gross total resection. It's the gold standard in treatment of these tumors, no matter if it's a primary tumor or a recurrence. And we also use here in Romania, and I think worldwide it's the same, adjuvant radiotherapy and chemotherapy with temozolomide. And although our techniques have evolved in the last years, we could not improve as much as we wanted the survival and the life of these patients. And let me show you why. You can see here the tumor, which has necrosis in the center, and you see the extremely large infiltrated area. And so gross total resection is actually extremely difficult to achieve, because you also have to have in mind the well-being of the patient, because you can't leave him or her with deficits. And you also have to know when there is normal tissue, and to differentiate the infiltrated tissue from the edema. Long story short, it is difficult, and you need a lot of experience to do so. And talking about experience, I will show you ours in the third neurosurgical department of Baghdad Arseni in the last 5 years, between 2010 and 2015. All these patients were operated by Dr. Vasile Ciubotaru, our chief of neurosurgery here. And we had 158 patients, 64 female and 94 male. Please note that I only talk here about those patients where we could achieve gross total resection, not those with partially resected tumor or with biopsied tumor. And as I said, we use adjuvant radiotherapy and chemotherapy with temozolomide in all patients. In our group, the mean age was 58 years old, with slight differences between male or female, but nothing significant. Here is the distribution on the cerebral surface. You see here that in the frontal lobe we had the most frequent tumors, And then in the temporal lobe, we also had tumors extremely large that were in more than one lobe. You see frontoparietal, frontotemporal, and so on. Mostly we had tumors on the right side, but again, nothing statistically significant. In our group, only 29 patients, 16 female and 30 male, underwent a second neurosurgical intervention, and the median progression-free time between the first and the second surgery was 9 months. And only 3 of these patients suffered the third surgical intervention. Maybe if we have time, I will discuss this subject too, because there are some problems here, and I don't know if these are encountered in other countries. So, what about the therapies? Numerous drugs have been tested alone or combined with radiotherapy and temozolomide. In my presentation, I only kept those that passed at least a second phase clinical trial, because we don't really need to talk about the other ones. And these drugs are targeting various molecular pathophysiological mechanisms. Some of them I will detail more in the next slides. You see here the epidermal growth factor, which is a common driver of glioblastoma progression and is found in nearly 40% of all glioblastoma cases. And phenotypic changes in this epidermal growth factor receptor can occur by overexpression, amplification, and mutation. And it can be targeted. I added here 2 articles from 2015. You see here vandetanib and nimotuzumab. This is a monoclonal antibody. Both of them target the epidermal growth factor receptor, and both of them proved at least partially efficient. Also, we have the P53 protein and the PTEN phosphatase tumor suppression. These 2 are at least now used as markers, and I couldn't find some specific targeting, some specific therapies targeting these ones. P53 is a well-known tumor suppressor protein that plays a fundamental role in the formation of high-grade tumors, and it initiates DNA repair or apoptosis if the DNA damage is irreparable. So it is logical that if there are mutations of P53, the DNA could not repair itself, and the apoptosis is not initiated, so the tumor cells can progress freely. And it has been correlated with the transition from low-grade astrocytoma to the high-grade glioblastoma. I will also like to make a comment here. The youngest patients we found, I did not write this in my presentation because I didn't want it to be too much, were those under 50 years old, were mostly with a second tumor, a recurrence from a low-grade glioma. So this thing does happen oftenly. So on. And about the phosphatase tumor suppression, it can be mutated. It is mutated in between 5 and 40% of glioblastoma, and can be a prognostic indicator. And we also have isocitrate dehydrogenase, which also favorizes the transition from low-grade gliomas to secondary glioblastomas. The mutation of this isocitrate dehydrogenase is now considered to be a fundamental step in this transition, and although it is rare in primary glioblastomas, which in our group were the most, it is found in 83% of all secondary glioblastoma cases, which is rather important, because if you could target this kind of mutation, maybe you could save at least a part of the patients. And I also added an article from 2015 in February about the detection of P53 mutations and also isocitrate dehydrogenase mutations in glioblastoma multiforme. And this article has shown that it could be useful for the determination of the prognosis of these patients, and there are studies to be made. Maybe we will do some. Also, I would like to talk something or a little about cancer stem cells, a component of glioblastomas or high-grade gliomas that can make the tumor resistant to radiotherapy. And as I said earlier, radiotherapy is one of our main treatment options. And first, these cancer stem cells were described in 2004. These have the receptor CD133 and are thought to be responsible for the maintenance and proliferation of the tumor. And it also has been made an experiment. They tried to transplantate some CD133 positive and some CD133 negative cells from patient biopsies in immunocompromised mice, and it has shown that only in those who have received the CD133 positive cells, it was developed a phenocopy of the patient's original tumor. And so targeting this kind of cells is a potential therapeutic strategy to eliminate the cancer stem cell population. And it has been tested, this monoclonal antibody, nimotuzumab, which actually targets epidermal growth factor receptors like the other ones I talked about, but it also reduces the number of radio-resistant CD133 glioma stem cells in the tumors. So it could be an adjuvant for patients who are already receiving radiotherapy, because it could improve the response. Next, I will repeat current standard of care in glioblastomas now. We have to do resection, of course. Neurosurgery is not the cure, but it is the most important step in treatment of these tumors. And the current standard is maximally possible surgical resection, of course, and but this is case specific. I said based on tumor size, shape, and the location of blood vessels, arteries, or maybe eloquent brain areas. And I would dare to add surgeon's experience, which is always extremely important. And surgical resection can be classified as gross total resection or subtotal resection when a complete removal is not possible or not achieved. And it has been demonstrated, you can see here an article from Oringer in 2012. He found, or they found, the team, that the 1 year survival is significantly higher for patients with more than 90% tumor resection compared to those with less than 90% tumor resection. It is also to be discussed about the 100% tumor resection, but as I showed you earlier, I don't think it is technically achievable. We also could use awake surgery if the tumor is located in eloquent areas, so we could test intraoperatively these functions and maybe extend some the margins of resection, but the prognosis still remains poor. Also, post-operatively, we perform radiotherapy, and this induces DNA damage, causing the cells to undergo apoptosis. We do 6 weeks of localized radiation therapy 5 times per week with concomitant chemotherapy. And resistance to radiotherapy can be problematic in glioblastoma, as this subtype of epidermal growth factor receptor, you can see here, could confer cellular resistance to such treatment options by upregulating the DNA double-stranded break repair machinery. And it has been conducted now, I think it's finished, a phase 2 multi-center trial of one substance molecule, which is specifically targeting this subtype of epidermal growth factor receptors, and now they will start the phase 3 trial. So it has been proven that this is efficient, this kind of strategy. And the chemotherapy current standard is temozolomide. And adding temozolomide to radiotherapy increased median survival at 24 months from 10.5% to 26.5%, which is a lot for these patients. And let's talk, enough with this, let's talk about the newer therapies. We could use, as I showed you already, monoclonal antibodies that can recognize surface receptors and ligands and prevent them from binding, from forming the receptor-ligand interactions, and so downstream the receptor activation. It has been approved bevacizumab. I know it is also used in Bucharest at the Oncological Institute. The Avastin is the name of the product, and it is targeting the vascular endothelial growth factor receptors, and that blocks the neoangiogenesis that the tumor does, because as the glioblastoma grows, it forms new vessels, so it could vascularize itself. And it was thought, and actually became true, that if we can block this neoangiogenesis, maybe the tumor would decrease in size and the prognosis will be improved. You see here a phase 2 study of bevacizumab in combination with temozolomide in patients with recurrent glioblastoma. This product is only used in combination with standard therapy yet. We also could do immunotherapy. There are some people who are attempting to re-engineer the patient's innate immune system in order to combat their own glioblastoma. And these groups are biopsying the tumor and then reintroduce in the patient's system the differentiated dendritic cells, thus promoting T-cell aggregation and elimination of tumor cells. You see here an article on the first personalized immunotherapeutic vaccine against recurrent, incompletely resected, treatment-resistant glioblastoma multiforme. And it has suggested that the efficacy is at least promising. And actually, they initiated a phase 2 clinical trial, so fingers crossed. Then, what I thought to be the most interesting new treatment is using oncolytic viruses. These are actually a potential treatment for glioblastoma because these viruses cannot replicate, are incompetent, replication incompetent, but except in specific cell populations such as tumors. And these viruses can target specific surface markers on the surface of the tumor, then infect the tumor cells and undergo lytic expansion, thus destroying the cell population. And then after the cell population is eradicated, it can remain replicatively incompetent, and the excess of virus can be eliminated from the patient's system with antiviral therapies. You see here extremely recent article about myxoma virus, oncolytic myxoma virus, that has been shown to induce apoptosis in brain tumor initiating cells and has enhanced survival in now mouse model of glioblastoma, and they think that this is a strong candidate for clinical translation, this kind of virus. And the last one of my slides, the nanoparticles that can be used as a vehicle for transporting different molecules, treatment molecules, because a big problem in treating central nervous system tumors, not only glioblastoma, is that the drugs cannot pass the blood-brain barrier, and so they do not enter the parenchyma. And some reports suggest that the surface modification of polymer nanoparticles can improve their ability to cross the blood-brain barrier, but it is now to be demonstrated whether these enhancements are large enough to enhance therapies. And in conclusion, current glioblastoma treatments have not improved overall patient survival rates to the level achieved for other brain tumors, of course. The best we can offer, I heard at the Congress, is 15 months compared to 30 months. These are the most, I don't know how to say, optimistic studies. And there is a critical need to understand how glioblastoma arises or evolves from low-grade gliomas. And I talked about targeted therapies. These therapies may prove to have limited efficacy because glioblastoma can arise from a variety of mutations, but we could try a combination of treatment approaches that may prove as an effective regimen for these patients. And thank you so much.
Thank you very much, Francesca. This is indeed a great presentation with so many references, so many experience presented. So I really think I enjoyed it myself, and lots of things I know about glioblastoma multiforme, and especially in this surgical realms, just you know went through my head while listening to you. So I think it is really a pleasurable experience to hear this presentation and have this all bound up in one place, and also hear something about Bucharest experience. So I would like to open the discussion for the panel. Does anyone have some remarks to say? I'm seeing
Yes,
that
please.
Abdallah is unmuted.
Yeah.
Okay, Abdullah, go ahead.
Okay. Thanks. Okay, first off, I'd like to thank Francesca for that presentation. It was really nice. I really enjoyed the presentation, and I just have a little question. Um, is glioblastoma known to grow in certain parts of the brain, like a certain lobe or certain area, or just can grow anywhere?
Um, I will answer only with what I do know and what I have seen. Mostly, it arises in the cerebral hemispheres. I also showed you in my presentation. If you want, I can put it back on. Uh, the lobes where it was most frequently encountered. We also had the cerebral glioblastoma, I think, in only two cases. So the answer to your question is yes, it can arise everywhere. I don't know in the brainstem, so maybe Dr. Bennett could help us with this one.
Yes, yes, I know about a case of brainstem glioblastoma. It's really, I can see that Rakesh is saying yes, but that it can also occur in brainstem, but this is very rarely. So most often in the hemispheres, as
I never had.
you said. Yes, yes, of course. Rakesh, sorry, did you or Abdallah, did you conclude your question?
Yeah, well, I just wanted to know the implications, like for the glioblastoma peripherally from the brain, because you know how the patient will come to the conclusion that okay, I have a glioblastoma because of I don't know if they have certain lack of I don't know motor function, visual impairments, and something, you know. But I just wanted to know if it because if it's you know confined to a certain area in the brain, then that would give a sign to a patient. But apparently, it's like everywhere. So.
It is correct what you say. The clinical appearance can orient you towards the place where the tumor is located, but these patients can present with anything from aphasia to motor dysfunctions, and also there are tumors that are not operated in our center, and we only do a biopsy to confirm the diagnosis and then send them to oncological institute to receive radio or chemotherapy if the oncologist thinks so. And so there are some cases. I actually met a 37 years old patient 2 weeks ago who had an inoperable glioblastoma, and it was tragical.
Okay, Rakesh, did you have any remarks?
Yeah, Francesca, it was a very nice presentation, and you were very clear with your concepts about GBM. And I liked your slides also. Each of the slides at the end, it was connected with the article, and that's very much necessary while you're presenting in such presentations. So I liked it very much. And in this GBM is the most common, and you went into the molecular details of that, and which is most common. So it will be very helpful for all of us in the panel because we are all students, and it is the most common. And you told us about P53, P10, CD133. It will be helpful for each of us in the panel. So you have given us some points to be remembered throughout our career.
Yes, of course.
So I would like to add to Abdullah's question. He was asking how do you diagnose clinically all tumors will present like with the same clinical symptoms. So I think these tumors mostly we diagnose by imaging characteristics differ along with the biopsy. So we these two imaging differs, the characteristics differs, and the biopsy.
Okay,
I,
can I show again? Because it is great what he's saying. Maybe I could.
yeah, I just added because he had a genuine doubt. Otherwise, it was a very good presentation. It was short and sweet as yeah, as it is, and I enjoyed it a lot. Thanks a lot.
Okay,
Great remark.
thank you. I want to show again the image with the MRI of the glioblastoma so they could see the characteristics.
Yeah.
Let me see. think it was at the beginning.
Can you please tell us what those three symbols at the right upper right form? That is the Walter Dandy one.
Yeah, that is Walter Dandy Neurosurgical Club, our club here in Bucharest. This is the symbol of the Baltazar Arseni Emergency Hospital, and this of our university, Carol Davila University.
Okay, thank you.
Here it is the picture. You can see the central necrosis, which is not usually found in lower grade tumors. You see the large peripheral edema that produces mass effects on the other structures. You can see that it is an infiltrative tumor. It has not so regulated margins. I don't know, maybe could you add something to this?
No, you have told almost all of it. So this is how we diagnose glioblastoma multiforme. Along with the biopsy will confirm the diagnosis. You have touched into all the points. Very good presentation once again.
Thank you
This
so
is
much.
wonderful how you can add one to each other with Rakesh's experience and your Francesca, and I really enjoyed this conversation and also question. Thank you, Rakesh. Well, we have a question from Leah, so I would like to try to Leah. Can you please unmute and see if your microphone is back?
Do you know how many people tried treatment with virus?
Okay, well, what Lee told me, so I will read the question. Can you say how many people have tried treatment with viruses for glioblastoma multiforme? Is that the question, Leah? Yes. Okay. So, do you have any thoughts about this, Francesca?
Yes, but I can't say for sure. I have seen a presentation at Cluj. If you remember,
Yes.
Slaven, you were there too.
Yes.
But I not extremely sure. It was a study made at Koç University in Turkey. Maybe we could send them an email. So because this work is not yet published, I think they had 10 patients or so.
Yes.
In that center, but I think it is better to just ask them and maybe say in another hangout.
Yes, may I just add to this that yes, in Cluj we had the pleasure to hear the lecture by Professor. I will try to remember his name. He's from Netherlands.
Sam Soraroglu.
Yes, he was, and also was professor from Netherlands, from where Viktor Volovic is at his residency. That is the Erasmus Medical Center in Netherlands. Yes, can you say the name again?
Demers, Ruben Demers.
Yes, no, I think it was something like this. I just can't remember. But this professor said that they have some experiments in Erasmus Medical Center in Netherlands. They are yet to be published, but they did treatments with viruses for astrocytomas and for gliomas. So they would inject the viruses into the area of the tumor, and then would put into isolation because of the possible infection, and they had some success. So they are satisfied with these results and they want to publish it. But we had a hangout with Professor later. I will try to remember his name, but these reports are still to be published. So. Yes, and this was great that you added, Francesca. That it was that we could maybe make a hangout about this question in the future, because this is really an amazing question, Leah. Thank you so much for remembering us about this aspect, because this is such an experimental treatment which may really be helpful in the future. As Rakesh agrees, and everyone else, do you have any questions, Rakesh?
Yeah, it's a very nice question by Leah, because we have to, as a students, we we have to go into research and have some innovative ideas rather than just going to temozolomide radiation and surgery. We should
Yes.
think of new things like viruses, targeted therapies. Yeah, we should, as students, we should always think about this. A nice question.
Yes, and I
Okay.
can tell you, Leah was active in this way, you know, experimental from the very start of her medical school. I remember when she was only a few months in the medical school, she already had ideas to do some researches. Fortunately, because of the, you know, some misunderstandings of colleagues on higher levels, she couldn't get this to do, but we really, I think it is something to admire about Leah. So.
Slaven,
Thank you so much for your interest. Yes. Yes, Rakesh, please. Oh, it seems that Rakesh is not responding. Okay. Well, I also have a question, Francesca, very shortly, because I do not want to take any more time. But in your opinion, we heard so much things about how many times should resection be done, surgical resection of glioblastoma when patient has it. So what is your opinion? What is the should resections be done at all or not? And how do you see this from a neurosurgical perspective? Please share with us your opinion. There is no right or wrong in this question.
Okay, actually, this is a great question, and I do have an opinion, but it is based on the specific patient because it could have he could have comorbidities which would limit our activity. Maybe if it's a younger patient, I would fight harder and I would operate as many times as I could. But in an elder patient, that would also have a risk of remaining with some sort of
Yes, yes, deficits.
neurological deficits. I could just stop at the first or maybe the second resection. It depends on the patient. It depends on what he or she wants, what the family wants. It is to be discussed, and I think it should be an multi-specialized team. We should also discuss with the oncologist, with the neurologist. This we should make a team.
Yes, yes, of
I
course.
heard about the patient operated 5 times, but not in our center. It was a young girl.
Yes, because the surgeons agree about the median of 3 resections, and after that, most of them do not go. And this is what. Thank you so much for your aspect on this question, Rakesh. Please, you
I
had some.
agree with that. No, I agree with that. There was some connection problem. I agree with that. That median of three repeat surgeries is agreed because surgeries, as you know, is a morbidity, adding on a morbidity. So I think 3 is a median which is agreed.
Thank you so much, Rakesh, for your expert opinion on this. Rakesh is a resident in neurosurgery, a famed one from India, so we are really happy to have you here and your knowledge. Thank you for sharing.
Thank you.
And Nicola and our other here respected members of the panel, Marco and Armando, do you have any remarks or thank you for listening?
Oh, yeah, I also want to say thank you so much. I love hearing about biomarkers, and I also didn't know about the new treatments, so I really enjoy it. Thank you so much. Really good presentation.
It is amazing to have you here, Marco. And Marco is in Bolivia. Is that correct?
Yes, I'm from Bolivia, Cochabamba, Bolivia. I study at San Simon University here, and I finished last year.
Yes, yes, it is amazing. So this is really a global project, and it is really great to see. What time is there in Bolivia?
Here's it's 4 o'clock, or already 4 o'clock. Yes.
Very, very interesting. Yes, because you can see it at me. It is dark. Also in Francesca and Abdallah, and Leah and Nicola. So
Yeah.
It is amazing. And Dr. Bennett, who's the leader of this whole project, is of Neurosurgical TV. It is still there at his place. So, and another participant from Japan, he is sleeping right now. So it is
Simon.
amazing. Simon, yes, Simon, our beloved Simon, who is really missing. And he's a medical student also in Japan. So we hope to get hold of him. You can follow him on many applications. Just as Abdallah is doing. Abdallah, you have a very interesting this text.
Oh,
Medical tutor.
Does it appear? Okay, it works. Yes.
Yes, it works.
Okay.
Yes,
Yeah,
can you say anything?
Yeah, that's my website. It's my name and then .com. It's my website, and I have a YouTube channel where I make like tutorials about medical subjects and so.
Great.
So, where I also usually vlog or all the conferences and workshops that I've been to are already there, like all the presentations I've done, and yeah. So you can also find some stuff from high school when I started this, like biology and chemistry and stuff like that. Yeah.
Great.
You must meet Simon Abdullah.
I've met him. We talked. Yeah.
Okay.
Yeah. He's also doing some some short YouTube clips. Yes.
Gentleman, he is a class. So a British guy in Japan. He's amazing. Well, yes. Also.
So Nicola and Armando wanted to ask some questions.
I don't have questions. It's a very interesting exposition for therapies that I never heard, and it's a good experience. Thank you.
Armando, thank you so much for your participation in this. Yes, it is a pleasure to have you here. Also, Armando is also in Bolivia, and it is also gay where he is. So it is really lovely to see colleagues from all around the world. And Nicola, do you have any remarks, please?
Yes, I have one question about glioblastoma. Is it somehow genetically connected, or it's just one for one? I mean, is transferred to children?
This is a genomic question, so it's very interesting. Maybe Marco can add something also from his experience.
Okay, should I answer? There are some genetic alterations, as I showed in my presentation, but I actually don't know if it is transmitted to children. I have not seen this kind of cases, but I think someone with far more experience than mine should answer this.
Well, we are not that much experienced. Rakesh maybe is. Rakesh.
No, I don't have an exact idea about this thing. So.
Yes, but you know, in my opinion, and this is only my opinion, it does not need to be correct. But as far as I know, most of the tumors, we could say all tumors, in order to happen, need to have a mutation. So you always have to have at least 3 mutations in the genome. And the professor from Greece, John. Just a second, I'm having trouble with names today.
John Giannios.
Yes, Giannios, exactly. John Giannios, yes, thank you, Abdallah. He was saying he's currently a leader in epigenomics and precision medicine, which tries to know the genome of the patient and treat him in this way. So he had some amazing hangouts where he talked about you need to have 5. Even 5 mutations in the genome in order to have cancer. So this is so deadly cancer that it is really aggressive. in this way, I think there is really ought to be some serious mutation, and it is now a question: is this mutation transmissible, or is it autosomal, so it doesn't pass on to another? To its, but I think, Nicola, that the question is that you need to have mutations, but is this transmissible? So this is a field of not aware of, but in my opinion, I would say that it is. You know, that there must be some genetic factor in this disease, as well as in other specific diseases which are very hard, you know, which medicine is really fighting today. And I think glioblastoma is really such an aspect of medicine, the thing that we would all love just to be eradicated and to stop, you know, murdering people in their best ages, because this is a tumor of this population. You know, it is not. I'm not sure, Francesca. Do you know maybe in which population is this tumor the commonest? I mean, the older people.
Glioblastoma?
Yes, yes.
Yes, it is more common in older people, as compared to low-grade gliomas, which appear between the third and the fourth decade of life, or something
Yes.
there, or maybe even younger patients. Glioblastoma are rarely seen in younger patients. They're mostly in the elder. And I also said that the youngest patients we had did not have a primary glioblastoma. It was a recurrence from a low-grade glioma.
Oh yes, yes. Thank you much for this answer, Francesca. Nicola, does this conclude your question, or do you have any?
Yes, thank you for the answer.
Okay, so we heard from all panel members. Rakesh wants to say something, if I'm correct.
No. I just want to say it was so nice presentation that I forgot my sleep. It's 2 a.m. here.
Oh yes.
Yeah.
Thank you so much, Rakesh, for representing the Asia and that part of the world. So Rakesh, our Indian, you know, one of the administrators of Neurosurgical TV and our beloved companion here.
Yeah, okay. Glad to be
So
part.
yes, thank you once again, Francesca. I think really your colleague can be proud of your presentation today and the knowledge you presented. Also with these questions, which were quite how can I say, specific and on the borders of medicine of today. So you handled it all great. I think no one can say anything wrong about it, or you were amazing. So I really think that this both Romanian and Bucharest experience and the students that they have there. So thank you so much, and as well as people from around the world, which are really glad to have here, and you're all welcome to present yourself, and also to join us in our future hangouts, because you are most respected here. Thank you. So we will now go into the ending of this. If anyone has any final remarks, please tell them, and we will close this for the day.
Okay, so thank you everyone for watching and for having me here. It has been an honor for me. Hopefully, I will try to do some more presentations. I don't know when, but maybe. And I expect to see some from all of you, because you are all extremely smart people here. And thank you, Slavin, for inviting me again.
No, you're welcome, Francesca. And Francesca was one, you know, when we asked this, you want to present, she said, well, I would like to present, and this is the product of her will. So it is amazing to have another presentation in this series. Okay, guys. So thank you so much for coming, and I'm just receiving a message from Dr. Bennett. Just a second. Dr. Bennett is founder of the Neurosurgical TV. And then he's also our link provider for today. So I'm Slaven Gorkovic, the leader of the student chapter of Neurosurgical TV. Okay, guys. So I think that that we can wrap this up for today. We can talk a bit more. We will just wait for Dr. Bennett to end this link.